Okay, thank you for whoever tried to write me something. Okay, all right, so here's a plan for this planned stand for today. So I get you for until 9:15, and then we're going to take a little break. And then Daylin, who is Chantel's preceptor or student for that's getting her master's, is going to start a conference on the pediatric respiratory system and some disorders that you have associated with that. She's giving the lecture today. And so Chantel wanted me to be sure to let you guys know that she will be setting up Canvas and her conference. So if you're invited to another conference during my lecture, heaven forbid, do not leave my lecture. She's just setting up for it. And then her lecture will begin at 9:30, and that will go until 1:50 today. I think you'll have a break for lunch. I'm sure you'll have a break for lunch. Or maybe you'll just go through lunch. I don't know. It's Chantel's class. You can do whatever the hell she wants. Okay? Okay. So what we're going to do today in my hour and 15 minutes is that there are no student presentations. So what we're going to do is kind of pick up where we left off yesterday. And then remember, you had that COPD learning activity that's due tonight. But you know what? This is going to be one of the highlights of the semester. I'm going to pull up the answer key to it. Yes, I am. And we're going to go over that specifically. And then if we have time at the very end, I'm going to refer you back to that note pages template that we started to discuss during the neuro lecture. And I'm just going to point out some things about it that you will want to include in your study. Okay, fine. So another thing is that I will get an adult respiratory review up to you more than likely tomorrow. Chantel will schedule hers. The blueprint for exam number 4 will go up Wednesday after her lecture. And don't forget, there is a quiz today on respiratory that is due by 10 p.m. tonight. And then you can review it if you're still up. Personally, I'm in bed. But if you're still up, then you can review the answers to that at from 10 to 10:15. Okay? Questions. I'm all about the questions today. Yes, I am. So I can get this up and going. I don't know why this mouse goes wherever the hell it wants. It just does whatever it wants. Let me see down here. I'm looking for questions. Trying. Okay. Oh, Kim, aren't you just sweet? Learning activity due at noon or 10? Oh, thank you for looking that up, Kim. I will change that to 10 p.m. tonight. Actually, I can change it to 11:59 because I think all learning activities are 11:59. I was going to try and get through it today. I will change the time on that because we were going to do it yesterday during class. So I will change that due date. Thank you for bringing that up. Thank you that you're awake and engaged. The whole class thanks you. All right, let's get started. Any questions, though, before I get started on that about what's happening? Okay, then we're good to go. All right, so let's begin with COPD. And there's some things about COPD that we need to pay special attention to. And one of the things that is high risk, because the tissues of the entire respiratory system, of the lower respiratory system, have been greatly affected because of chronic disease over the years. And when you have chronic inflammation, then it kind of changes the tissue. I don't mind telling you. It changes it. It doesn't function the way it usually does. The bronchial tree becomes highly susceptible to cancer. And we're talking about the the bronchioles, clear down to the bronchioles. So the person is highly, highly susceptible to respiratory infections. So they have this high mucus volume or secretions in the lung. And don't forget the respiratory tree itself is inflamed. And so the lumen is much smaller. And so they have a tendency when you have high mucus secretions that for bacteria to develop. Yeah, it does very, very easily. And so they have these huge reoccurring respiratory infections. So some of the signs and symptoms of that is, of course, that they're going to have a fever, they're going to have an increase, they're going to have increase in secretions, it's going to hurt to cough. There will be some inflammation of the pleuritic membranes. They will have increased shortness of breath. They, of course, will have an increased white blood cell count. And, of course, because of the secretions that are blocking the diffusion of gas exchanges. Hi, Kylie. Oh, there she goes. Muted again. So because of these high secretions that are blocking the gas exchange, then they are going to become hypoxic, or their SpO2 is going to be way lower than 90%. And just FYI, in case we have never discussed this before, is that 90% is the... Oh, hi, Kim. You look so furrowed there for a minute. So, so the thing about it is 90% is it. When you do SpO2, 90%, anything lower than that, then, for a period of time is going to cause some problems. It's not going to meet the metabolic demands of the body. So, but one thing I want to stress here too with respiratory is that if you have an SpO2 of 95%, does that mean that the body is getting appropriately ventilated? Amy, good. You said yes, ? And the answer is no. But I am proud of you for answering, risking it, putting it out there. So this is the deal with that. Remember what SpO2, and it can be there, right? Oh, that's absolutely correct because of the inversion that you have here. So let me tell you about SpO2. First of all, what is it? And this is very much, you're going to learn this in EKG in the Lex, or ECG. Sorry, EKG was the German pronunciation or spelling of it. Now it's changed to ECG, but back in my day, at the bedside, it was EKG. Anyway, with the ECG, remember what it's doing is monitoring the electrical current in the heart that measures every time that one of those nodes clicks and sends the heart into a pumping, contracting movement. And the same holds true with SpO2. What it's measuring, it's not measuring the exact percentage of oxygen that's in the blood. What it's measuring is the number of hemoglobin that are carrying oxygen, or the number of red blood cells that are carrying hemoglobin that are carrying oxygen. So the thing is that you can have 90% of your red blood cells carrying oxygen, but what if you have anemia? Yeah, so there's not as many red blood cells there. So even though your SpO2 or your pulse ox is going to say 90, 92%, you have to further assess the patient and make sure that they're getting ventilated appropriately, that they are getting the respiratory metabolic needs met, or the tissue's metabolic needs met. You have to do that. You have to further assess. You cannot be dependent on the ECG alone. They have, well, I'm not going to go into Chantel's lecture on cardiac. I'll let her say that for you. But the thing is that you can have these monitors that do fabulous things. But if you are totally dependent on them, you're not going to be a good nurse. You're going to in fact, you're going to end up in trouble. You have got to always be assessing, always looking for further signs and symptoms of hypoxia. So when you have respiratory insufficiency, the definition for that is basically that the metabolic needs of the body, oxygen needs of the body, are not being met. And so even though your SpO2 can be, or your pulse ox can be reading 92%, you have to further assess the body and to make sure that their cap refill is going just fine, that the color is just fine, that they're not having an increased work of breathing, that their rate and rhythm is just fine. There's other things that you have to assess for as well. But let's go back to respiratory infections. So because of this inflamed bronchial tree, and because there's an excess of secretions in that tree, then there will be a bacteria that develops, and you will be at high risk for respiratory infections. So another thing that we talked about, and I wanted to explain this a little bit better than I think that I did. What could be worse? I know. Is the cor pulmonale. Now, the cor pulmonale is a heart cardiovascular problem. And so if all right, so, okay, I'm trying to figure out a way to explain this the best. So the thing about it is that when you have these little alveoli that are in the respiratory system that are at the end of the bronchial tree, they're in the bronchioles, or the very end of the bronchioles, they're in grape-like formation, and each one of those grapes is covered with a capillary. Remember, those little grape-like structures are only 1 cell thick, but they are totally encapsulated with a capillary at the end of the vascular system in the arterioles. So they are incorporated here. So when there gets to be some kind of issue with the flow of blood to those capillaries, and it's obstructed it somewhat, and it can be because of pulmonary hypertension. It could be a lot of different things, but when it becomes a respiratory issues where the alveoli become inflamed themselves, and so that gas exchange cannot take place, the blood begins to back up, and then it backs up clear through the cardiovascular system because the right ventricle of the heart is feeding the lungs. It's pushing that deoxygenated blood into the lungs to get reoxygenated. But if there is inflammation in these alveoli and there cannot be any gas exchange take place, or there becomes some obstruction to that free flow of blood from the arterial system into the venous system, which happens at the capillary level, then the blood begins to back up. And as it backs up, it gets backed up into the larger arteries, and then it gets backed up into the right ventricle. And so you have right-sided heart failure. So I wanted to clear that up a little bit. I'm sure I did with that fantastic explanation. But if you have any questions about it, just know that heart failure that is related specifically to the respiratory system, not to the cardiovascular system. You can get right-sided heart failure that is totally a result of the cardiovascular system and problems going on there. But when it's related totally to the respiratory system, it's called cor pulmonale. And so this is when you, again, don't have a gas exchange taking place. So you are going to be you're going to start having hypoxemia and hypoxia because the saturation of oxygen in the blood is going to be decreased. So, of course, when that happens, what happens? When you have decreased oxygenation in the blood, you're going to have increased dyspnea. You're not going to have the oxygen you need to meet the metabolic demands of the body. So you're going to have extreme fatigue because there is backup into the right ventricle. Then it starts to back up systemically. So your gastrointestinal system gets engorged with blood, and you start getting edema. One of the first signs and symptoms of right-sided heart failure is going to be systemic edema, beginning with the dependent extremities, so in the feet. You can have warm, cyanotic hands and feet with bounding pulses. Why? Because systemically the blood is backing up everywhere in the body. So there's a lot of blood there. That's why it's warm. But there's not oxygenated blood. And so the hands start becoming cyanotic, the feet become cyanotic. You have bounding pulses because you have this backup blood in the periphery. You'll have pulmonary hypertension, distended neck veins. We'll go over this pretty much in the cardiac lecture that we talk about. So we'll get to know this pretty much more. That was perfect grammar. Yes, it was. So, but I just need you to know that cor pulmonale is related to respiratory issues, not necessarily cardiovascular issues. All right. So what are the goals that we want to accomplish? Did you just yawn during my lecture, Kim? That was so rude. I think this is stimulating, titillating. So anyway, so what we want to do is, number one, is reduce the signs and symptoms of this. And so we want to remember fatigue is huge for people that do not have enough oxygen in the blood. So they will have any kind of activity intolerance at all, not necessarily exercise, but any kind of activity intolerance. In fact, I had a friend that his husband was in atrial fibrillation, and they were out shopping, and he was hanging on to that shopping cart for dear life, and she asked him just to step across the aisle and get some bananas. And so he stepped across the aisle in the produce section, and by the time he picked up the bananas and was coming back, he was totally bent over, out of breath, ready to just fall over. And it's just, if the body is not getting oxygen, you just are exhausted. There is no energy for anything. Okay, so we want to reduce the risk for exacerbations and to disease progression. So we talked about one of the biggest issues that we had with COPD is the risk for infection. So what do we want to do for that? Get them vaccinated. They need their flu shots. They need their pneumococcal. Over the age of 65, they start offering pneumococcal vaccinations for anybody over the age of 65. In fact, this is probably one of the IM injections that you're going to give in the hospital setting in clinicals all the time. Before they're discharged, they are asked if they want a pneumococcal vaccine, and which will help them from getting pneumococcal pneumonia. And it's an annual vaccine. So you'll get it 1 year, and then you'll get it the next year, and then you're okay. But this is offered to everybody in the hospital over the age of 65 when they are being discharged. You need to avoid crowds, and that type of thing. You need to wear your masks, social distancing, all those kind of things. And of course, smoking cessation. Don't ever disregard that as an answer. You always choose it. I don't care what the question is, what it has to do with, what the scenario. If the option is there for smoking cessation, you choose it. Just go ahead and choose it. Just a little strategy when you're taking tests. And then your treatments are going to be, of course, antibiotics and mucolytics, and of course, antitussives. Mucolytics thin the secretion, antitussives reduce the cough. However, you have to be real careful with antitussives because you want the person to cough. You want them to bring up the sputum. You want them to have a productive cough. But sometimes there's a dry hacking cough that they cannot. It's like when you have chronic bronchitis, you just cough and cough and cough, and you're not necessarily having a productive cough, and you can't sleep at night and that type of thing. So that's when you want to probably consider using antitussives. But you got to be careful with that with somebody that has COPD. Not COBD, COPD. All right. Just making sure I covered everything. Okay, so I think we mentioned this yesterday in the lecture. I want to make sure that you understand that people that have COPD, usually they are going to require supplemental oxygen in the late stages of the disease process. But typically, we are always using low doses of oxygen. And that is because, remember, this is a chronic disease. So their body has compensated for the deficits that they're getting as much as it possibly can. And they've been living for some time with the inability to completely exhale all the oxygen in their lungs, and they become accustomed to living with this low oxygen level and high carbon dioxide level in the bloods. So one of the compensation things that they utilize is that the body utilizes is it changes the respiratory drive from being respondent to high oxygen levels in the blood to high carbon dioxide levels in the blood to high oxygen levels in the blood. So we don't want to over-oxygenate them. So usually when we do COPD, we have them strictly on a nasal cannula, and we have them usually at 2 to 3 liters, sometimes 4 liters of oxygen. But we need to keep that in mind for these patients with COPD. Okay, here we go again. Up and over. Can I get something to match? I don't know. Here we go. All right. So we talked briefly yesterday about nursing interventions for COPD. You need to know these. What is pulmonary rehabilitation? What are the breathing techniques? What is positioning? And we talked just briefly about this because we ran out of time. So this is one of the reasons why I wanted to go over this again. And that is with pulmonary rehabilitation, it's talking about educating the patient about living with COPD. We talk about the progression of the disease process, what is going to happen, and we set goals with them. But with pulmonary rehabilitation, let me see. Nope, it doesn't. Okay, with pulmonary rehabilitation, it involves education and exercise training and pulmonary muscle reconditioning. So, for example, one of the things that we're going to teach them is that they don't want to do any kind of activity where they are having to keep their hands over their head. What? Why would we teach them that? I don't know. Anybody have an idea why we would teach them that? Anybody still awake? Anybody going to look at this recording later? Okay, fine. I'll tell you that. So the deal is something related to opening the diaphragm. Amy, I just love you for being really there with me today. Mark claims that he's awake, but he spelled it wrong. No judgment, people. It is early. There's no judgment here. Okay, so here's the deal. The same muscles, accessory muscles that you use for breathing, are the muscles that you use to keep your hands over your head. So this is why with somebody with COPD that is so dependent on the conditioning of their accessory muscles to help them expand the lungs as much as possible. We don't want them to do anything to keep their hands over their head. Interesting little tidbit, isn't it? Who wants to be a millionaire? Okay, so the next thing that we talk about, and we talked about this yesterday, was the diaphragmatic breathing or abdominal breathing, where we have the book on the abdomen and we have them. Oh, what is the position that they're in? Don't know. Supine with what? Knees bent. Excellent. Thank you, Kim. Thank you. Through all those yawns. Thank you. So, yes, and that's one thing. Ooh, why would I mention that? I don't know. Maybe you'll see it in the future. But diaphragmatic breathing or abdominal breathing has to be when they're in the supine position with the knees bent. And then you put a pair of shoes, but who would want dirty shoes on your stomach, even over your clothes? No. So put a book there. Yeah, that's better. And then teach them to learn to breathe with their abdomen. And then we talked about pursed-lipped breathing also, which slows down the breathing rate. We use this for people that are hyperventilating. We use this technique for people that have asthma, that are finding it very hard to breathe. But we also use it for people that have hyperinflation of the lungs, because we're trying to exhale as much of the air in those alveoli as possible. So how many seconds in? 2. How many going out? 4. Exactly. All right, the last thing that we're going to talk about is positioning. And you should have learned about this. I didn't mention this yesterday because I know I taught fundamentals at one point in my life. But positioning, postural drainage, for postural drainage. Anybody know what the position is for that? Does anybody care? Upright. Nope. Okay, so here it is. So let's say that you have consolidation in your right lower lobes of your lungs. So we start with chest physiotherapy. And chest physiotherapy, oh, wait a minute. You can't see my hands. Watch me use my new desk. Oh, looky there, people. Impressive, isn't it? I know. I knew you'd love it. My desk moves up and down. Theoretically, every hour I'm supposed to stand up because standing is the new walking. Yes, it is. You're not supposed to sit at your desk for 8 hours a day. I purposely don't, but for this display purposes, we're going to lower my desk. See, the problem with this is you get this area in view. That's why I raise it during lectures. But anyway, so chest physiotherapy is where you cup your hands. Oh, you can't even see them. Okay. And you do this to the patient's chest, front and back. Boom, 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 boom. And you do that for 2 or 3 minutes. Now, if you're super duper pooper respiratory therapist, then you have these little circular vibrators, and you put that on the person's chest. But what that does is breaks up the secretions, the thick secretions in the lungs. And then we need to get rid of it. So what did we say? Where was the consolidations? The right lower lobe, I think. So what we're going to do is put the person on the left side with the right side up. And then we're going to have kind of a Trendelenburg position where their little butt's up in the air and their chest is down, or their head is down on a pillow. And that's going to allow the broken up secretions in the right side of the lobe, because we're laying on our left side, to migrate down, because we're in the Trendelenburg position, through the trachea, through the bronchial tree, to the trachea, to the back of the throat, where they can be coughed and spit out. Yeah. That's called postural drainage. Postural drainage. That was a poignant pause. I'll try and give you those poignant pauses whenever I remember things that you might see in the future. I'm just saying. Sleep on, people, for those of you that are under the covers. Okay, so we talked about diaphragmatic breathing yesterday. We're talking about pursed lip breathing today. Okay, so one thing that you're going to have to be very cognizant of when you're taking the unit exam and the NCLEX is exactly what is the nursing diagnosis. So we're sitting here and we're talking about ineffective breathing patterns. We're talking about impaired gas diffusion. And we're talking about ineffective airway clearance. So what do you think is the definition of ineffective airway clearance? Something blocking the airway, but now we can have something like stridor, where there's inflammation of the epiglottis up there, where is obstructing airflow. So that would be obstruction, but clearance. There's your key word there. What are we talking about? Clearance. There we go, Amy Cooper. We can effectively cough up mucus and secretions. So this is a strategy that I want you to implement when you're looking at your unit exam, is what is the nursing diagnosis and what are the keywords that we're looking for in that diagnosis? And when we're talking about clearance, I cannot clear inflammation of the epiglottis. I can't cough, cough, cough and make it go away. But I can cough and clear the secretions or the mucus and make it productive. But if I have a diagnosis of ineffective airway clearance, that means that my coughing is not effective. It's not bringing up those secretions. So what do you think I can do for this? Educate, exactly, Jessica, exactly. But what are we going to educate them on? Breaking up the secretions. And how do we break up those secretions? We just talked about it. Chest physiotherapy, turn, cough, and deep breathe, exactly. Positioning, Mark, exactly. We are putting them in the postural drainage position. Suctioning. Hydration, so we want to keep those secretions thin. Oh, just read the slide, people. Read the slide. There you go. So this is one of the things that you have to do is when you're taking the test, and they give some kind of, it's like some, it gives you some kind of scenario in which the person is coughing, is trying to bring up mucus, that type of things. We want, or they give you a diagnosis of an ineffective airway clearance. You want to look at interventions that are specific to clearing the airway, and that means it's possible. Things are possible. Remember, with stridor, where there's inflammation, asthma does have mucus, but it's also greatly related to inflammation and the narrowing of the airway. So don't be distracted if there's interventions on obstruction there for obstruction. Because obstruction is not the same thing as clearance. Okay, fine. Incentive spirometry, exactly, Megan. That's another one that you got to do. Open up those lungs. Okay, impaired gas exchange. This again can be the result of what? I just realized my button is opened. So I hope you didn't see anything inappropriate. So what would be the cause of an impaired gas exchange? CO2 poisoning, there you go, or carbon monoxide. Mucus secretions in the alveoli, exactly. This is when we're starting to talk about pneumonia. Okay, so there's secretions that are blocking that diffusion. So we want to keep the patient's head, neck, and chest in alignment. And we want to think about thinning those secretions so that they can be cleared from the airway. We always have to monitor for respiratory status, because if you are not compensating for this inability for gas exchange, then things can go south pretty quickly. And so it's vital that we are monitoring the situation and that their respiratory status continues to improve and not digress. So, of course, when there is an impaired gas exchange, you're going to become hypoxic. What did we say yesterday was what is a must for hypoxia? Oxygen. Right. And so we want to provide supplemental oxygen. They're going to need that extra oxygen in the blood. We're going to teach them how to cough, and we may have to provide certain medications like antibiotics that may be causing bacterial growth in the alveoli. And remember what happens when bacteria starts to multiply. One of the byproducts of that increase is toxins, which then inflame the lungs. Okay, we talked yesterday too about nutrition and less than body requirements. And like I said, you cannot eat and breathe at the same time. So whether you recognize it or not, it can be unconsciously. You take a deep breath and put something in your mouth and chew it up. And so the thing about it is, and weight is such a huge issue, especially with elderly people. And I'm not talking about how much a person weighs. It is an indicator of the best indicator of how much nutrition they're getting. So it's so important, in fact, that in the MDS, MDS is for long-term care facilities. They have to give weekly reports for people that are in skilled nursing units, or monthly reports on each resident's weight. And if greater than 10% is lost in a 1 month period of time, then MDS, the Medicare Centers for Medicare and Medicaid Services comes in like a fly on butter, and they want to know everything about this patient. And because weight is the best predictor, weekly weight, not a daily weight. If you'll remember in Wendy's lecture, she talks about daily weights being the best indicator of the fluid, the water that's lost or gained overnight. But we're talking about weekly weights, or we're talking about monthly weights, is an indicator of their nutritional status, how much they're eating, if they're overeating, if they're undereating. So one of the problems with people that have COPD is that they are just so tired. They are so tired. It's exhausting. Not only are they afraid of aspirating, but they can't breathe at the same time. And if you're not getting enough oxygen in between bites, then it becomes it's fatiguing. It's too much. And so they begin to lose weight. And so there's different things that you can do. I can remember back in fundamentals, there was a test question. It's been several years, so I still remember. But here there was a test question. What can you do for a person that has COPD before meals? And to help them. And it was rest for 30 minutes. So resting for 30 minutes, but also prior to eating will hopefully spare some energy for them. But also if you use a bronchodilator 30 minutes before the meal, that may help to open up the bronchioles. Food selection, you want to make sure that that dry foods, you don't want to give them that because it requires water. And then now you're drinking and eating between breathing. It just becomes very, very difficult. And if they're not getting the nutritional needs met, then provide them Ensure or Boost between meals to make sure that they're getting as much protein as they possibly can. But this is definitely, when you're talking COPD, then you are definitely going to look at this as a priority nursing diagnosis. Okay, and then we're going to look at activity intolerance. So again, this should be pretty familiar to you because this is, again, a fundamental aspect of nursing care, and that is when a person has an activity intolerance because of fatigue, maybe it's because they're short of breath, then you want to pace the activity with periods of rest. You just don't do it all at once, a little bit at a time. And you know how I told you that we want to keep the person's independence. That is our basic goal for caring with an elderly person, is keeping at their highest level of functioning. So we want them to be as independent as possible. However, recognize that with COPD, the person has respiratory insufficiency and they are going to require assistance with their ADLs. So again, let's look at the scenario, let's look at the test question, let's look at the information that we have. With COPD, they are going to require assistance because they have activity intolerance. So we want to teach them to conserve their energy. We want to have them on minimal exercise programs. I'm telling you, have you ever seen an exercise program in a long-term care facility? It's the greatest thing. I think I could do it, in fact. I tried really hard. It's like passing the beach ball over your head and then under your head and over your head and then down your head. It's cute as it can be. But anyway, so we want to provide progressive exercise as much as they can tolerate. Why? So that their muscles stay conditioned. We always want to have them use oxygen when they are ambulating, because it is going to deplete them of oxygen to get them up and moving. But that's something that we want to do because of the complications of immobility. And planned intercourse. Mark, can you tell us about that? Mark, are you still with us? Oh, planned for a little last night, did you? Okay, so this is what's happening with planned intercourse. Apparently, now I've been divorced for 18 years, so I am a little hazy. I've forgotten a lot of this stuff. So apparently, when do you want to have sex? Not all the time. All you boys, back off. It's the first thing in the morning when you have COPD. And there's a test question on it. So make sure you talk to your significant other about it and try different times of the day when it's best for you. Okay, so ineffective breathing pattern. This is something that is a huge issue too. Anytime that somebody has shortness of breath, they have an ineffective breathing pattern because they're sucking air. So you've got to find, when you have this ineffective breathing pattern, it's not going to be effective very long. People cannot sustain an ineffective breathing pattern. They can't. So you always want to assess and make sure that this is one of those continual assessments that you walk into the patient's room, patient that has COPD, and just look at what is their work of breathing. Is it worse than the last time I was in here? And is it better? You just always need to assess it. And what are we going to tell if they have an increased work of breathing? What are we going to look for? Accessory muscles, exactly. Retractions, exactly. Because why? People cannot sustain it for a long period of time. It just costs too much energy to keep that. So we've got to get them into an effective breathing pattern, one that they can sustain and one that sufficiently ventilates the body. So you need to, keep an eye on that pulse oximetry. You have to determine and treat the cause. So what is causing this exacerbation all of a sudden? Have they been exposed to smoke or secondhand smoke? Have they got anxiety? Many of these things that can cause this increased respiratory rate or ineffective breathing pattern. So when a person is short of breath, always put them in the semi-Fowler's or high Fowler's position. Why? To expand the lungs. It is take the pressure off the chest. Exactly. This is the only position that you can be in, standing or sitting straight up. It allows full expansion of the alveoli. Otherwise, you have some part of the lung that is dependent, which means that the weight of the body is on it and will not allow that alveoli to expand. So we want the patient in high Fowler's position. Use diaphragmatic or breathing techniques. Again, pursed lip breathing is used to slow down breathing. Okay, and again, have any of you been underwater where you're swimming? Oh, that's what this article I read. So I couldn't believe this. This was with Navy SEALs. And who's that guy that won all the gold medals in swimming? Mark, what's his name? Mark, what's his name? I can't remember his name. Mark Phelps, that's right. So Mark Phelps even came out against this holding your breath as long as you possible. For swimmers, one of the things, the techniques they used to increase their speed was to learn techniques to hold their breath as long as possible underneath the water so they don't have to slow down to take a breath of water. Take a breath of air. So he came out against this technique. Navy SEALs have come out against this technique because they have found that people that hold their breath underwater can faint underwater and drown. Yeah, it's true. You can drown in 2 feet of water. Yes, you can. If you're trying to hold your breath as much as possible and then end up fainting underwater, you can drown. And that's something, and that's why they came out against it. But anyway, why did I tell you that story? Because it just popped into my head. But I was going to ask, how many people have swum before and tried to swim as long as they can, holding their breath? And then you're in a contest with your brothers or something, I don't know. And then, you're starting to panic because you can't get air and the anxiety increases. And the same holds true for people with COPD because it's a progressive disease, which is terminal. There's no cure for it. And so and we talked about a little bit about this yesterday, you sit there and you breathe in and out. I don't have to think about it. We don't think about the breaths. We don't think about inhalation. We don't think about exhalation. But somebody with COPD, the harder it is for them to get air. They have what we call air hunger, and they just can't get enough air. And it just panics you. So anxiety is a huge priority diagnosis because having anxiety will put you in that flight or fight mode and cause you to increase your breathing rate, your heart rate, and everything else. So the one thing that you got to do is stay with the patient. Stay with the patient because it calms them down. It gives them a little bit of assurance that they're not alone. And then you purse lip breathe with them. You can teach them relaxation methods, and you can also provide anti-anxiety medications if you need to. Xanax goes a long way. They won't give them Xanax. They'll give them Ativan or something like that. But just be aware that this is going to be part of their care. Is times when they're very, very anxious. You can administer IV morphine as ordered, but I will tell you this, again, something that you have to be very, very careful with, just like the antitussives, is that morphine decreases the respiratory drive. And if you're dealing with respiratory issues, you got to think about that. Yeah, you do. All right, let's see where we're at. I'm getting on the downhill side here. Is that the very last one? Okay, it is. All right. So the next thing that I want to look at bring up is your learning activity. So I am going to do my screen share, and somebody's going to have to verbalize to me that they can see. This is going to be screen 2.
Hey, Vicki.
Yes.
I just had a question.
Yes.
Out of all of those nursing diagnoses, which one would you prioritize with a COPD patient?
Excellent question. And that is one thing that we were getting ready to discuss. So let's just discuss it while we're here right now. I can get out of this thing. My mouse. I have 3 screens going, and trying to get a mouse on the screen I want drives me insane. Okay, let me see. Can I get out of this? Use your entire screen. All right, I can't see you guys. Can you see me?
Let's show your presentation though.
Yeah, just a minute. I'm trying to get this out. How do I X out of that? Oh, hold on, people. I hope I don't lose you. Oh, wait a minute. I'm sorry, just a minute. There. Oh, All right, I think we're okay. Okay, so the question was priority diagnosis. Yeah, it was over 30 seconds. Oh, look at you get to see my hand. Ooh. Okay. There we go again. All right, so this was an excellent question, and this is one of the things you definitely want to look at when you're studying for the test. And I was going to bring up the notepad pages in just a minute. So let's look at this and look at the top 3 diagnoses. So ineffective airway clearance. So what is happening when that happens? You have excess secretions, but are those excess secretions in the alveoli? Are they in the bronchial tree? What's going on there? Let's look at the next one. Impaired gas exchange. So there is no exchange of oxygen, carbon dioxide within the alveoli. Nutrition less than body requirements. Activity intolerance. And ineffective breathing pattern.
Vicki,
Yes.
when you have a question like this where it's like, what is your priority nursing diagnosis? Are you looking at the patient as if they have all of these problems at the same time?
No.
Okay, so you're just looking
because this is the scenario can be that you have a patient with this, you have a patient with this diagnosis, a patient with this diagnosis, which are you going to go see first? So that's what we're trying to do when we talk about priority diagnosing is, okay, here are the patients with these different conditions. Which one are you going to address and monitor closely and monitor first? So that's what we're trying to get you to do, because you're going to have to do that all the time as a nurse. But let's think back to one of the strategies that you use in nursing, and you will utilize this throughout your nursing career. And that is basically, we go by Maslow's pyramid of needs. So what is the ground level for Maslow's pyramid of human needs, or human needs pyramid, or whatever? Maslow's pyramid. So what is the bottom level?
the physiological or
The physiological. Okay. Emotional is going to be security, safety, and then the third one is going to be, of course, love and psychosocial, that type of thing. Okay, so let's go back to the basic. We always started the basic basement of the pyramid. So physiological needs. So is anxiety physiological, or is it emotional or psychosocial?
emotional?
Yeah, so it's psychosocial. It is important, but out of all the diagnoses that we just looked at, is it the most important? No, it isn't. So ineffective breathing pattern. Now we know that can't be sustained for a long period of time. So this is pretty high priority, but let's keep looking. So I'm going to bring up in just a minute those notebook pages that you use as a study guide, and we're just going to kind of go over it. But one of the boxes that has there is list the 3 main nursing diagnoses or priority nursing diagnoses for these patients. And this is going to be right up there with it. Because why? Because a patient cannot sustain life for very long doing this. But is it the top one? Let's go back and look. Activity intolerance. This is important because it's mobility, but is it as high as air? Is it as high as elimination? Is it as high as nutrition? No, but it's pretty up there, because you got to be able to feed yourself. You got to be able to eliminate. All that kind of stuff requires energy. But is this the highest one? Just let's keep looking. Nutrition less than body requirements. This is pretty important. It is more important than more than body requirements. But so it's up there. You have to have food to survive. So it's going to be on the bottom level too, but is it the highest one? So let's keep looking. Impaired gas exchange. Can you have that? Can you live without the exchange of oxygen and carbon dioxide? No, you can't. And then this one, ineffective airway clearance. So out of all of these, probably number one is going to be what? Well, I just didn't mean to give a little hint there, but just you guys rate them all right now. Everybody take those nursing diagnoses and rate them 1, 2, 3. I will give you all of 2 minutes to do it. Ineffective airway clearance, impaired gas exchange, imbalanced nutrition. Thank you, Maddie, for answering. Anybody else want to put it out there? Ineffective gas exchange, impaired airway clearance, imbalanced nutrition. Imbalanced nutrition was number 3.
I put impaired gas exchange as number 1.
And let's talk about this because this is important for you guys to be able to do. This not only to pass the test, but as a nurse. So impaired gas exchange is actually number 1. Because if you, and what are the ABCs? Airway, breathing, and circulation, right? But, and there's really, if you go into a CPR situation, you are not going to be able to, if they have consolidation and no gas exchange, there's really nothing you can do about it if you find the person on the side of the road. But for impaired gas exchange, that is the number 1 thing, because if that ain't happening, you ain't breathing at all. Now, the second one is going to be ineffective airway clearance, or it's going to be ineffective breathing pattern. Okay, the imbalanced nutrition. How long can we go without food? Several days. How long can we go without air? 4 minutes and your brain starts to die. So then we have to break it down any further. So we have impaired gas exchange, we have ineffective airway clearance, and we have ineffective breathing pattern. So if we have it all, the thing about it is that how long can we go with ineffective breathing patterns or ineffective airway clearance without dying? Which one is more important?
The pattern.
Pardon me?
Pattern would be more important because you can't sustain that.
For a period of time, exactly. The clearance, on the other hand, what are we talking about exactly with the clearance? If you have to do the Heimlich maneuver on somebody, how long can you go? So if they're totally obstructed, if your scenario states that they're totally obstructive, then they become number 2, and the breathing pattern becomes number 3. But if they have an inability to cough and they are not totally obstructed in both lungs and all lobes because of these heavy secretions, they're totally whited out on the x-ray, then breathing pattern would become number 2, and the airway clearance, where they have to strengthen their muscles to cough up sputum, would be number 3. So you have to kind of look, again, this is nursing, we're looking at all the data. And if you had 3 patients and each had one of these, impaired gas exchange, impaired breathing pattern, and impaired airway clearance, or ineffective airway clearance, or whatever, then we have to look at other data to support what the priority is going to be. Does this make sense? Who asked this question originally?
It was me.
Perfect.
Okay.
801, 821, perfect. It was a perfect answer. I mean, a perfect question. Oh, it was a perfect answer. I'll go ahead and say no. Just kidding. Just kidding. So it was a perfect question for what we're talking about here. Is that we've got to look at what is going to cause the greatest amount of harm to the patient out of all these diagnoses. And if they are not exchanging air and gas or carbon dioxide, they're going to die quicker. If they have an ineffective breathing pattern and they have mucus in the lungs, or they have a productive cough, and they're able to cough, but it's just not very effective, then the ineffective breathing pattern is going to cause them to decompensate faster than the ineffective airway clearance, as long as they're not obstructed. But remember, the word was clearance, not obstruction. Any questions? All right, let's bring this over because I'm going to post this. Why? Because I love you guys. I just think you're working too hard, too hard. So all you have to do is, I don't care. I had this out here as a learning activity. We don't have time to do it. We're down to about 4 minutes here. So I'm going to put it out there for you to copy and then re-upload it to Canvas. But here's the deal with this, and these learning activities aren't just bullshit, people. I'm sorry. Some of you, I get that on my evaluation every semester. Your learning activities are bullshit. And you know what? I don't take it personally. I don't take it personally. But the whole purpose of this is to have you consolidate some of these notes into things that you can study for the test. So I'm going to bring this over and we're going to try once more. I don't know if it's possible, but we're going to try once more to make this as part of my presentation. Let's see, here we go. Now, again, this totally occludes my screen. So you guys have to talk to me because I can't read what you're saying. So there that goes. I'm going to put this on screen number 1. Why won't this go scroll down? Why won't this scroll down? Share your screen. That's what I want to share. I can't bring this up. Oh, hell's bells. Forget it. I'll just post it. I'll just post it onto I'll just post it onto Canvas and you can look at it there. But here's it. Here's it is. It's a case scenario or a case study where a person has COPD, and then you're the home health nurse and you're looking for interventions that you can do for the person with these different nursing diagnoses. And we have the ones that we just talked about here, and food selection and activity intolerance. And so this puts concisely interventions that you need to know for each of these diagnoses. And I will tell you right now, these are going to be on the test. So yeah, you want to study this. One last thing in the few minutes that we have as well. I'm trying to see. I don't know that I can bring this up. I don't know what my issue is here. I have no idea. Anyway, on the nursing notes, or there's a note pages for respiratory there, and it kind of outlines the things that you could fill out in your notes. You can, your notes from this lecture, I'm sure they're vast, pages and pages long. You can condense that down and with just keywords to help you remember the things that you've learned. It's not verbatim, everything that I've said, but it also talks about priority diagnosis. There's a point where you will start writing what are your priority diagnostic labs or procedures that help diagnose somebody. What are the priority medications, if you wanted to include that? And what are the priority interventions that are you going to use? Now, you got to remember, look at the different interventions here for impaired gas exchange and impaired or ineffective airway clearance. They're different. So make sure that your interventions are specific to the diagnosis that you've written. So you would put down, if for priority, what are the priority interventions that you're going to implement for this patient. And as a nurse, this is what the NCLEX is trying to teach you. This is what we're trying to teach you, is that there are specific things you do for specific things that are occurring with your patient. And it all has to be supported through an assessment. You have to collect that data. You can't just say on here, what is the priority intervention, that even though increasing activity tolerance is an intervention you want to implement with somebody's COPD, it's not necessarily going to help them with clearance, airway clearance. Do you understand what I'm saying? Yeah, I'm sure you do. So that is what. Now, one more thing that those note pages have that is going to be included in your NCLEX. And sometimes in the Unity exam, but not as much as you're going to find it on the NCLEX. And that is where you have your 5. We have 6 CUSIN competencies. The last one being informatics, and we don't worry about informatics. But the others are going to be safety, evidence-based practice, patient-centered care, quality improvement, and evidence-based practice. Did I say that already? What was the 5th one? Evidence-based, say patient-centered care. Oh, teamwork and collaboration. So, and it says down there on those note pages, it gives you examples that you can use for a person that has COPD. And they're not really that specific that you find in the textbook, but you can Google it anywhere and just fill in for yourself what specific interventions can be done to meet the criteria for those competencies. Because that is where it's all out in healthcare right now, those things. Okay, people, you have until 9:30. I am going to let you go get a cup of coffee, caffeine pills, energy drink, food, or anything. Oh, or pee. Yeah, go pee. And then I come back at 9:30, and there will be a conference on PEDS. Respiratory disorders. Is there anything, a coffee enema? Yes, McKenna. Too bad the cameras are going off. I would personally love to witness that. Anything else? Okay, I love you guys. Guess what? Did you realize that next Monday we're going to meet face to face? Oh my gosh.
We're so excited to see your face, Vicki. It's your life.
But I got to tell you this, that we'll be all behind masks. You won't be seeing me. We'll just be under the mask, but it's okay. We will just bond with our masks on. All right. Love you guys. We'll talk to you later. Don't forget, 9:30, be there, be square. See you. Bye.